Right, I think we're good to go. Um, Welcome everyone to our Oral Boards webinar from the SSAT Resident Fellows Education Committee. As always, very excited. This is one of our most popular webinars each year, and we hope that it be a very educational experience for everyone who's listening currently live, and then anyone who may want to watch in future years. I know I've personally found this to be a very helpful resource, as have many of my mentors in the past. This year, we'll be doing a little bit of a different format. We've pre-recorded some of the videos from various institutions and their mentors, including the Fox Chase Cancer Center, UMKC, Yale, and UT Southwestern and Dallas. And so we've pre-recorded a few scenarios already between our panelists who I'll be introducing shortly, as well as resident mentees at their institutions. And we'll play the videos of the various mock oral scenarios for everyone, and then have our panelists, um, have our panelists then dissect them and give their thoughts on things that the trainees and mock examinees did well, things that they could brush up on, and any tips and tricks they may have for specific scenario types or when you may find yourself in a hole. So without further ado, I'm going to just introduce our panelists. First, we have Dr. Sanjay Reddy, who's a pancreatic cancer surgeon and the division chief of surgical oncology at the Fox Chase Cancer Center in Philadelphia. We have Dr. Alex Rossi, who's an assistant professor and a fellowship-trained colorectal surgeon at the Yale School of Medicine. We have Dr. Hadley Freeman. She's a assistant professor and fellowship-trained surgical oncologist at UMKC and recently graduated from the CGSO fellowship at Loma Linda. And then lastly, we have Dr. Anthony Tanous, who's a clinical associate professor at the University of Texas Southwestern. He's a emergency general surgeon, acute care trauma surgeon there, who also deals with burns and works in the ICU. So without further ado, I think we're going to start playing our first video. Probably it's going to be the first video is going to be from Dr. Reddy and his group at the Fox Chase Cancer Center. Is that correct?
That's correct. Yeah. And I'm sure you said it in Anish, but Anish and I are your moderators for this evening. And I'm Prab Chetani. I'm a second year surgical oncology fellow at Fox Chase. I'm happy to be here. We'll play Dr. Reddy's first. Let's see if we can just share this here. Time, share sound. All right. How's that showing up for you, Anish? Can you see that? Okay.
It looks good on my end. Thanks.
Awesome. Great. All right. I'm going to mute and then we're going to play this.
Hello, I'm Sanjay Reddy, surgical faculty at Fox Chase Cancer Center.
And hi, I'm David Sear, first year surgical oncology fellow at Fox Chase Cancer Center.
So we'll begin the oral board examination with the first case. Dr. Sear, this is a 32-year-old gentleman that is brought to the emergency department after a high-speed motor vehicle collision. He was a restrained driver, sustained a brief loss of consciousness, and is now complaining of abdominal pain. You're in the trauma bay, and please start beginning with your initial assessment.
Okay, so I would start first by assembling my team, assess the patient, make sure that they're connected to continuous heart monitoring and supplemental oxygen. I'd have my team establish 2 large bore IVs bilaterally, and I would send off my trauma labs, so CBC lights, creatinine, INR, PTT, group and screen. I would start running IV fluids, IV crystalloid, and call the blood bank. I then begin to assess this patient according to ATLS principles, A, B, C, D, E. So for airway, I'd make sure that their airway is patent and protected. Breathing, I want to examine their oxygen saturation, look for bilateral chest rise and any absent breath sounds. Circulation, I'm looking at heart rate, blood pressure, any signs of external hemorrhage. For disability, looking at pupillary reflexes and GCS. And then for E exposure, I would make sure the patient's fully exposed, log roll them, and look for any concomitant injuries.
Good. So the airway is patent. The O2 saturations are approximately 98%. Blood pressure is a little bit soft, 90/60, somewhat tachycardic in the 115, 120 range. and his GCS is 15. What would you want to do next?
Okay, so again, I have IV crystalloid running. I call the blood bank and consider starting empiric blood transfusion. And I would, again, look for any signs of hemorrhage. So I would order perform an abdominal fast exam.
Okay, so as you're doing this, his blood pressure is now 80 over 50. You perform the fast exam and you notice some nonspecific fluid in the pelvis.
Okay. So given that this patient has a positive fast, they're a blunt trauma, and they remain hemodynamically unstable, then I would plan to proceed to the operating room for an exploratory laparotomy.
Okay, so in the effort of transporting the patient, the pressures are now even a little bit more labile. You've initiated so far a liter of crystalloid, 2 liters of crystalloid, and you're still waiting on blood.
Okay, so I would initiate a massive transfusion protocol given that they are actively bleeding. And sorry, just to clarify, am I en route to the OR or am I still in the trauma bay?
Still in the bay.
Okay, so I would proceed with my other adjuncts, so chest X-ray, pelvic X-ray, make sure I'm not missing any hemothorax or a significant pelvic fracture, and I could also apply a pelvic binder sort of empirically.
So you do that. Nothing else is worrisome or concerning, but in that massive transfusion protocol initiation, you now rapidly get your blood, and you initiate the blood, and the patient's pressures are now normalizing at this point. So you've now reached the operating theater. Patient is somewhat stable. Tell me what your management at this point would be.
Okay, so in constant communication with the anesthesiologist, I'd have the patient supine position on the operating table with both arms out. I'd prep very widely from chin to groin or to thighs. I'd perform a generous midline laparotomy from xiphoid to pubis.
Okay, good. So you do the laparotomy. Immediately you encounter large volume blood and clots.
Okay, so I want to make sure I pack off all four quadrants and get some sort semblance of control and visualization. And then I would systematically explore the abdomen for sources of bleeding. So initially looking at solid organs, so liver, spleen, kidneys.
Okay, good. So upon doing so, you pack the abdomen. Pressures are now stabilizing. Anything specific you want to ask your anesthesia colleagues at this point?
So I'd want to make sure that I want to ask about the patient's hemodynamics, if they're able to catch up with their blood products. Um,
Good. So they say, Dr. Sear, patient's now stabilized. They're infusing blood rapidly. Things seem to be settling down. So as you sequentially remove your packs, you see a brisk bleeding from the left upper quadrant.
okay, so brisk bleeding from the left upper quadrant. So I'm worried this could be a splenic injury. So I would very in a controlled fashion remove that pack and inspect the spleen and look for an obvious source of hemorrhage there.
You try that. It is quite rapid, and you suspect that there's a major injury towards the hilum of the spleen.
Okay. So if there's a major injury to the hilum of the spleen, so we need to get proximal control of this. So I would sort of mobilize the lateral attachments of the spleen so I can mobilize the spleen medially and place a clamp across the proximal splenic vessels just proximal to the hilum.
Okay. So you do that. You do the splenectomy. Any other areas? And again, at this point, the bleeding seems to be controlled. The patient's now stabilized. Any other areas you want to focus attention on, having had taken out the spleen?
So I want to look for any other injuries in that area. So I look at the tail of the pancreas, colon, splenic, small bowel as well.
Okay, so everything was assessed. The bleeding seems to be controlled. Patient's now more hemodynamically stable at this point, still hypotensive.
Okay, so if I'm confident there are no other injuries in the abdomen, and I'm communicating with anesthesia that the patient is um, still unstable, potentially becoming coagulopathic, I might need to convert this to a damage control setting, um, in which case I would pack the abdomen, apply a temporary abdominal closure, and transfer him to the ICU for resuscitation.
Okay, so you do just that. You leave the abdomen open. Patient is still hypotensive, is somewhat acidotic, pH of 7.1, a little bit hypothermic. But nonetheless, you pack the patient, you take him to the ICU for resuscitation. After 24 hours, you've achieved some hemodynamic stability. Labs are improving. What would you want to do now?
So sounds like they've gotten some adequate resuscitation. I would bring them back to the operating room for a second look laparotomy to assess for any other missed injuries at the time of the initial trauma laparotomy, perform any necessary reconstructions if there were any to be done, and hopefully close them.
Okay, so you do a second laparotomy, you inspect the area, you don't see anything that looks alarming, there's no bleeding, bowel's a little bit distended, but you suspect you should be able to close the abdomen.
Okay. Um, Okay, so I would do a thorough washout. I'd place a drain in the left upper quadrant, and I'd close the abdomen primarily.
Okay, good. That concludes the first scenario. Um, we'll now go to the second scenario, Dr. Sear. So this is a 62-year-old woman who is referred to your clinic after undergoing having had non-specific abdominal complaints, underwent cross-sectional imaging, and was found to have an incidental pancreatic cyst. How would you
Okay,
begin your evaluation of the patient?
okay, so I would go and assess the patient. I'd take a detailed history and physical. Um, on history, I'm specifically looking for um, symptoms that could be related to this pancreatic cyst, such as pain, jaundice, um, any systemic symptoms such as weight loss or fevers, um, any history of pancreatitis, any risk factors for pancreatic cancer, so family history of pancreatic cancer, for example, as well as their age.
What about any more worrisome sort of red flag things that you would really put on high alert in this situation?
Right. So if I'm worried about red flag features or aspects of their history would be previous episodes of jaundice, recurrent episodes of pancreatitis, or if they have new onset diabetes.
Okay, so the patient denies any evidence of pancreatitis, jaundice, new onset diabetes. Having had now obtained the history and physical examination, what would you do next?
So next, I want to perform some investigations. Uh, routine blood work, CBC lights, creatinine, but also LFTs, bilirubin, amylase, or lipase. I would want to get tumor markers, specifically CA19-9, and then imaging. So either a CT, a CT pancreas protocol or MRI pancreas.
Okay, so you get some basic blood work. White count is 15. Uh, total bilirubin is 2.3. And CA19-9 is 45. The rest of the lab work is unremarkable. You go ahead and you do get additional imaging by way of an MRI, and a 3.5 centimeter cystic lesion is seen in the body of the pancreas. There's some septations. There's nothing obvious in terms of a solid component, and the main pancreatic duct is dilated to about 6 millimeters. What are your differentials at this point?
Okay, so um, my differential diagnosis would include intraductal papillary mucinous neoplasm. I think that would be towards the top of my differential. Um, a serous cystadenoma, a pancreatic pseudocyst, a mucinous cystic neoplasm.
Okay. So you have these in the differential diagnoses. At this point, the patient's in the office. You're reviewing this with them, the blood work and the imaging studies. They ask you, Dr. Sear, what do you want to do now? What should we do? Should we go to surgery?
So I wouldn't go straight to surgery at this time. I want to perform some additional investigations. So I'd send them for an endoscopic ultrasound with a fine needle aspiration of the cyst. Specific characteristics of the cyst on FNA that I'd want to know about include the fluid CEA, amylase, and cytology.
Okay. So the endoscopic procedure is completed. You get the cytology back. There's mild atypia. The amylase was very elevated, and the CEA in the fluid was about 500.
Okay, so I'm concerned that this is a intraductal papillary mucinous neoplasm. There are some worrisome features here, including the size of the main duct. It was, I believe, 6 millimeters, and then the size of the cyst itself is greater than 3 centimeters. So I then would, depending on the patient's fitness for surgery, that would sort of dictate my recommendation.
Okay, so let me give you two scenarios then. Say this is a 85-year-old patient in a wheelchair with multiple medical comorbid conditions. How would you propose the next steps for that patient?
Yeah, so I think I would, this patient sounds like they may not be the optimal candidate for surgery, so I would recommend close surveillance at this time with either MRI or EUS every 6 months.
Okay. And now, scenario is a 35-year-old healthy patient. What would your recommendation be for that patient?
Yeah, so this patient sounds like a good surgical candidate, and they're young, so I would recommend resection.
Okay. So you proceed with surgery, spoken to the patient. Could you describe the operation, the ways you would approach this?
Yeah, so this lesion is in the body of the pancreas, so it should be a good candidate for a distal pancreatectomy. And I would perform a splenectomy with that as well. I would do this minimally invasively, so laparoscopically. Upon entering the abdomen, I'd want to make sure I really.
Anything you would want to offer the patient prior to surgery?
So I would want to make sure that I stage the patient. I don't know that I have fully staged them for metastatic disease at this time. So
Okay, so you get some additional imaging. CT chest is unremarkable, but the patient's concerned with the splenectomy portion of the procedure. They
right.
ask if anything additional needs to be done.
Yeah, so we want to assess them for splenectomy vaccinations as well.
And what would your protocol be? When would you give them to the patient?
I would give them to the patient just prior to surgery.
Okay. So you went ahead with surgery. You did a successful distal pancreatectomy and splenectomy. Intraoperatively, is there anything that you're specifically looking for and assessing?
So I would want to assess for any evidence of metastatic disease, so any peritoneal disease. I want to ensure that I'm getting adequate margins around the lesion itself. And then specifically with IPMN, I want to ensure that we have adequate negative margins. So
Okay.
I would send the pancreatic duct margin for frozen section at the time of
So
intraoperatively.
you do that. You see no evidence of distant disease. The margins are negative. and the surgery otherwise was uneventful. Now, post-op, what are the things you're worried about in the first few days following pancreatectomy?
So for pancreatectomy, I want to look for any evidence of any postoperative complications. So potentially most worrisome is evidence of a pancreatic leak from our resection, our staple line. So I'd be monitoring drain output, volume, and testing the fluid for amylase
Okay.
on
When will
day
you test the fluid for amylase?
Pardon me?
What day would you test the fluid for the amylase?
Day 3, and depending on that, then again on day 5.
Okay. So patient's postoperative course at this point is unremarkable. Your amylases are normal. You've advanced the patient's diet, and the patient goes home. On the pathology, you find evidence of invasive cancer that was arising in the cyst itself. What
There
would you
is
counsel the patient at this point?
so evidence of invasive cancer in the cyst itself. So we're now treating this as a pancreatic adenocarcinoma. I would again, if I've already staged the patient, if I hadn't already staged the patient, I would do that. I then present them at multidisciplinary tumor boards and recommend them for adjuvant systemic therapy.
Okay, great. That concludes the second scenario. Good job, Dr. Sear.
All right. Excellent. Thank you so much. Dr. Reddy, we'll give you the first word. How do you think David did? What do you think that he could have done better? And then we'll open up the floor for discussion beyond that.
Great, thanks, Prof. So, a couple things. I think the most important thing in these scenarios is first the composure part of things, right? So, good eye contact. The tone of voice was strong, was good. It was natural, it flowed. That calm cadence for the questions and answers back and forth, I think, is really important. Um, the delivery I thought was pretty fluid, right? I think it was very conversational. I think that's an important part for these board examinations. You want to give as a conversational outlook as you can in these situations. You want to avoid unnecessary long pauses. You want to limit that filler language where you're not sort of using extra words just to sort of fill time and fill conversation. The positive, it was just a positive tone. I thought the first impression is really important, and I thought David did a good job. Um, I think one of the important things too is just being able to be clear and concise and logical about your explanation. When you have a structured approach like this, it makes the conversation a lot easier for both the examinee and the examiner. Um, I've always sort of encouraged, and I think David did a good job here, where there's a method of case preparation, right? So everyone is going to have their own way in which they're going to start their examination, right? So you start off with the history, the physical exam, the labs, the scans, et cetera. And I think having that consistent and concise framework is really important. I thought David did a good job with that. There's key things, right? Covering the presentation, the assessment, the decision making, the intra-op portions, the post-op portions. You really have to stick to that structure uniformly. I think one of the other important things is you have to let the examiner guide the transition when appropriate, because the alternative is you're then anticipating and rushing ahead. So I thought David did a good job of waiting to be prompted to go to the next step. So I think overall composure, professionalism, communication skills are important, and I thought he did a good job with those.
Completely agree. Dr. Freeman, do you have any thoughts on what David could have done better?
Sorry, I couldn't find my unmute button. Um, no, not necessarily, not anything in addition to what Dr. Reddy just mentioned. I thought the flow was excellent. Um, I thought his methodology for working up the patient and kind of going through the scenario was very appropriate. Um, really good eye contact. That's something that people struggle with a lot when they're going through these cases. That was something that I did notice. So, really only positive things on my end.
Awesome. I will mention one thing. I've noticed, and this is something that I tried to do a lot of when I took my boards and I prepped. is I did notice he was looking down to his left a lot. And one thing to be mindful of is now we're firmly in this era of Zoom oral boards, and they do have moderators who are watching your board scenarios, and you do want to be mindful of how much you're looking down in a particular direction, up in a particular direction. They do have flags that will raise for cheating and things like that. Not to say that he was, but just be mindful of that as an examinee. Doctors Rossi and Tanus, do you have any thoughts?
I mean, I agree with all the comments that were made. I think to me, the most important part of his presentation was that he was composed and logical, and you could follow everything he was saying, which I think is, 80% of the battle at least.
I don't have too much to add. I admittedly logged in a bit late, but from what I saw, it was very easy conversation and very well structured. I would have passed these scenarios without a problem.
Yeah, perfect. All right, so why don't we move on to Dr. Tanus, your mock orals. Let me just share here. Okay. And of course, let me know if any AV problems arise here.
All right, Dr. Heslan, thank you so much for coming today. I don't want to waste any of your time, so if that's okay with you, we can go ahead and get started.
Sounds great.
All right, so you are in your clinic and you're seeing a 50-year-old female who presents with an outside mammogram that revealed an area of concern. How would you approach her?
Okay, did I get to review the mammogram ahead of time?
Before we get to the mammogram, how would you interview this person with an abnormal mammogram?
Okay, I would start with a comprehensive history and physical, focusing specifically on any clinical history of a breast mass, any pain or any asymmetry, or any nipple discharge. I would also ask her for any risk factors for breast cancer, including a personal or family history of breast or GYN malignancy, estrogen-related exposures, including menarche, menopause, pregnancy or oral contraceptive or hormone replacement history, as well as a full bilateral breast and axilla physical exam.
Okay, so she has no pain, no masses, no nipple discharge. For her risk of breast cancer history, no family history of breast cancer, no family history of GYN malignancy. Her age at menarche was 13, age at menopause was 45. She's 50 right now. She's had 3 pregnancies. She was 24 when she was pregnant the first time. She has no history of prior breast biopsy. She's taken OCPs for 5 years and 5 years of hormone replacement. On exam, you said you would examine both breasts and axilla. So she has no dimpling, no asymmetry, no skin changes. On palpation, there is a palpable right breast mass at 10 o'clock, 6 centimeters from the nipple. And there's no palpable lymph nodes.
Okay. In which breast? The right breast?
Right breast, yes.
Okay, sounds good. Thank you. Okay, so no palpable lymphadenopathy with the right breast mass. I would refer this patient for bilateral diagnostic mammograms.
Okay, so they come back and they show that in her right breast, she has a 3 centimeter mass in the upper outer quadrant, and the remainder of the breast and left breast are benign.
Okay, I would obtain an ultrasound guided corneal biopsy of her right breast mass and ask them to leave a clip at the site.
All right, so we'll go through some scenarios about how the biopsies come back, and I want you to tell me how would you approach each biopsy result and what you would talk to the patient about. Okay?
Okay.
So in the first scenario, the biopsy demonstrates a grade 3 invasive ductal carcinoma, ERPR positive and HER2 neu negative, with a Ki-67 of 20%.
Okay. Grade 3. Did I get the size?
It's, I think 3 centimeters, what we said.
Okay. 3 centimeters, no negative, ERPR positive. I would counsel this patient on her operative options, including a partial mastectomy plus a sentinel lymph node biopsy followed by radiation versus a total mastectomy with a sentinel lymph node biopsy.
She decides she wants a partial mastectomy with sentinel lymph node biopsy. Um, how would you do the sentinel lymph node biopsy?
Okay, so to do her sentinel lymph node biopsy, I would utilize dual tracer technology, technetium-99, as well as blue dye, and inject it at the site of the mass. I would then massage the breast for 5 minutes before proceeding. I would then make a small incision inferior to the hair-bearing area of the axilla. And utilizing blue dye as well as my gamma probe, I would identify any clinically suspicious or radioactive or blue sentinel lymph nodes. I would identify the most radioactive sentinel lymph node utilizing my gamma probe and take that, as well as any node that was within 10% of the primary sentinel node.
Okay. Let's say the sentinel lymph node is negative. Does she need any further treatment?
So this patient has ERPR positive, node negative, HER2 negative, breast cancer. I would proceed with an oncotype.
Okay. Only for you proceed with oncotype regardless of what the biopsy shows.
If the sentinel lymph node is negative, I would I would refer the patient to medical oncology, but I think that oncotype could guide their care here.
Okay, let's say her oncotype comes back as high. What does she need
Okay.
now?
This patient would need adjuvant chemotherapy with adriamycin, cyclophosphamide, and Taxol. So before proceeding with that, I would get an echo to assess her heart function, assuming that she doesn't have any history of congestive heart failure. I would place a port. I would counsel her that she would need adjuvant chemotherapy.
What kind of therapy?
This patient would need adriamycin, cyclophosphamide, and Taxol, as well as whole breast radiation still. And then she would need actually follow-up endocrine therapy as well.
Okay, let's say she comes back 4 years later with a recurrence. She has a 2 centimeter mass in the right breast, same side, no palpable adenopathy. You did staging scans, they're all negative, and she has an MRI that shows no other areas of disease. What are her options now?
Um, okay, has this patient been discussed at tumor board at this time?
Yes,
Okay,
they
so
say follow up after surgery.
okay, great. So this patient, his only options at this time is actually mastectomy with a sentinel lymph node biopsy, and I would additionally consent them for the possibility of an axillary lymph node dissection at this time.
Describe to me how you would do her mastectomy.
Okay, so for her mastectomy, I would proceed with for total mastectomy, I would proceed with the elliptical incision for the entire nipple areolar complex, as well as her prior lumpectomy scar. The borders for my dissection and my skin flap would be the clavicle superiorly, the sternum medially, 2 centimeters below the or inferior to the mammary fold, inferiorly, and the latissimus dorsolaterally. I would also resect the pectoral fascia.
Okay. How would you do her axillary lymph node dissection?
Um, Assuming this patient needs an axillary lymph node dissection, I would remove all of her level 1 and level 2 nodes. So the border for that, the borders for my dissection for her axillary lymph node dissection, similarly would be the chest wall, the axillary vein, the latissimus dorsi, and the serratus. I would also identify the long thoracic and thoracodorsal nerves at that time.
Let's say you injured the thoracodorsal nerve. What would you do?
Am I at a facility that has plastic surgery available?
No.
Okay, I would to debride both edges and attempt repair with adoperlene.
Okay. I think we ran out of time for more scenarios, but I want to move you to a different type of case altogether, if that's okay.
Okay.
Different patient population altogether. You're now in the in the ER, and you're consulted to see an 8-month-old female with bloody stool. The child was well until 2 days ago, and when she developed a low-grade fever, vomiting, diarrhea, the mother noted blood in her stool 3 hours ago. Her 3-year-old brother had vomiting and watery diarrhea 5 days ago, but is now back in good health. This baby has no medical, surgical, neonatal history, no allergies, very healthy baby. Physical exam, I'll just give it to you now. Her temperature is 100.9, heart rate 160, blood pressure 90/50, and her O2 sats are 100%. She's initially quiet, but she draws her legs up and cries out loudly, intermittently, and suddenly. After a minute, she stops crying and vomits a small amount of green liquid. Her abdomen is soft, mildly distended, no point or rebound tenderness. Her diaper has a small amount of dark blood within it. The external anal exam is normal. So that's all your physical exam. How would you like to proceed?
Um, okay, I would ask if there was any other relevant history to this episode.
This is all you get from the mom.
Okay, so in the ER, I would proceed with a workup with the basic labs, including a CBC and a CMP and a lactate.
CBC normal, CMP normal. Her potassium is 3.2, but aside from that, she has her CO2 is a little high, her chloride is 110,
Okay, so
but
consistent with
everything
her
else is normal.
presentation,
Yeah. Yeah.
vomiting. Okay, I would proceed with the KUB.
KUB shows multiple distended bowel loops, but no gas in the right side of the abdomen.
Okay. Could I get an abdominal ultrasound?
Sure. The ultrasound shows a target sign.
Okay. So this presentation is consistent with intussusception, likely reactive based on the brother recently being sick, likely benign. Could I please consult radiology for an air enema?
Okay. Do you want an air enema or a barium enema?
Um, I would initially proceed with an air enema. I want an air enema.
Okay. So the radiologist is able to reduce it with an air enema, but you get called back shortly after because the patient is having colicky pain again.
Okay. I would proceed with a repeat air enema.
All right. The radiologist reduces it again, but several hours later, the patient is having constant severe abdominal pain.
Okay. Constant severe abdominal pain, different from the
Mhm.
primary episode.
Less episodic. It became constant now.
Okay. I would consent this patient for laparoscopic reduction of intussusception at this time and proceed to the OR.
Explain to me a little bit how you would do this surgery.
Okay, I would start just with three laparoscopic ports. I would position this similar to what I would do for a pediatric appendectomy. I would have a two bowel grasp, or I would introduce three trocars, including a camera as well as two bowel graspers, and would start by running the small bowel.
Okay, you run the small bowel, you find an area of intussusception.
Okay, so I would gently grasp the bowel and at the proximal end, hold traction and gently milk it out from the distal end of the intussusception.
Okay. Would you resect it, keep it in place?
Um, is there any obvious mass?
You don't
Or
feel a
you're
mass.
like reactive lymphadenopathy?
You don't feel a distinct mass. There's some lymphadenopathy thickening of the mesentery, but that's it.
Okay, is there any dusky appearance of the bowel?
No.
Okay, so my bowel appears healthy. It appears like there's no distinct mass. I would leave it.
Okay. Let's say new scenario. You're asked to see a 20-month-old male in the ED with a lower GI bleed. He had been well until 5 hours ago, and then the mom started seeing bright red blood mixed with stool when changing his diaper.
Okay.
Since then, he's had a couple of bloody diapers. No medical history, physical exam, vitals are very normal. He's alert and no distress. No distension of his abdomen, no point or rebound tenderness, no mass. Anal exam is normal, but you can see that he had a bowel movement with bright red blood and clots. How would you proceed?
Any relevant birth history?
No, all negative.
Okay. Any prior history of constipation, personal or family history?
No,
Okay. I would proceed with basic labs again, CBC, CMP, and a lactate.
completely normal.
Okay. Can I get a KUB?
Normal.
Okay. Could I get an ultrasound?
Unremarkable.
Abdominal ultrasound is unremarkable.
Yes.
Okay. Could I get a CT scan with iodine
Uh,
and no contrast?
sure. It's unremarkable.
Okay. Okay. Could I proceed with a Meckel scan?
Okay. So what are you thinking now? What is your differential?
So my differential at this time is a occult, likely lower GI bleed, possibly upper GI bleed that doesn't have any localizing symptoms on CT scan, and so I think most likely for a patient this age, the Meckel's diverticulum would be high on my differential, as well as neck. However, they have completely normal labs and they're old.
Okay, so you get the Meckel scan and it's positive.
Okay. My Meckel scan is positive. I would proceed to the operating room for a diverticulectomy.
How would you do that?
Okay, so I would consent the patient for laparoscopic possible open resection of diverticulectomy, possible small bowel resection. I would proceed to the operating room and position laparoscopic ports similar to what I would do for an appendectomy using a bowel grasper and two bowel graspers and a camera port. I would identify the terminal ileum and the cecum and then move proximal to find any site there where a diverticulum would be most likely.
Where is it usually relative to
Um,
the...
2 feet proximal to the ileocecal valve.
Okay, you find the diverticulum. What do you do
Okay.
now?
I would resect the diverticulum and leave the small bowel intact.
Okay. How about, you're not worried about the ulcer that is bleeding, that is caused by the diverticulum?
If there is an active bleeding ulcer or the external wall of the bowel looks friable or compromised, I would consider a small bowel resection, but in this case, I would likely proceed only with a diverticulectomy.
Okay, let's say the Meckel scan was negative in this child.
Okay. Um, I would still proceed to the operating room for a laparoscopic exploration with a high suspicion of Meckel's diverticulum.
Uh, how come, given that it's negative?
Just based on the patient's age and the fact that Meckel's diverticulectomy is not completely sensitive, or Meckel's scan is not completely sensitive for Meckel's diverticulum.
Okay. All right. Well, Dr. Hassan, thanks for your time today.
Okay, thank you very much.
All right. Well, thanks to Dr. Tanous and Ryan for those scenarios. We'll actually open up the discussion with you, Dr. Tanous. What do you think Ryan did well, and any areas of improvement or tips that you have based on those scenarios?
Thanks, Anish. Good to see you. It's been a while. So, I think Ryan did very, very well. I think, this is Ryan actually is in the lab right now after doing 2 clinical years. This is some of his first mock orals, and he came in prepared, very professional, speaks very well. Some of the stuff, he stayed organized even when I repeated the question that he already answered, and sometimes your examiner is a human being as well. They may have missed something you said, or they may not be the best examiner in the world, but he stayed unfazed when he responded, and that's very important. Um, I think one, note that I had for him is he don't be afraid of explaining your rationale and your differential instead of like tack, tack, tack. I would order this. I would want that. I want this. It's okay to say, I'm thinking, this is my differential. These are the three things that I'm thinking, and I want to get this study to be able to differentiate it a little bit. The rationale is a bit what the examiner is looking for and what your differential is. And sometimes you get no history at all. Patient shows up and you have to elicit a lot of history, like in the first case, the breast case. And sometimes you're given plenty of history. And in general, the examiner feels that that's sufficient history for you. So asking for more history, you're going to end up getting a lot of, you got all the history you need. So we really just need to delve into the case itself. So avoid like going into minutia of history that after getting ample history yourself. One other thing is this calling consultant thing, expect that for a lot of some complications, you won't have too many consultants available. So expect that they're out of town, they're not picking up the phone. So for some of the common complications, for the common procedures, it's good to have a good idea of how to handle those when it's simple. And for cancer cases, always remember to discuss an multi-D tumor board and involve the oncologist. That's something that is heavily tested.
Yeah, thanks for that, Dr. News. As always, learned a lot from you. So yeah, I think those are some very good and high yield points for our listeners that I think apply especially to like these scenarios, the oncologic reasons, but all scenarios in general. Dr. Rossi, we'll go to you next. Is there anything you'd like to add regarding these scenarios?
Again, I agree. I think that the examinee was very well spoken. He came across very eloquent and prepared and confident without, there wasn't like any sense of overconfidence, just he clearly was prepared, knew what he was talking about, was organized, especially on the first scenario.
Yeah, definitely agree. Ryan was solid. And Dr. Freeman, Dr. Reddy, do you guys have any thoughts or that you'd like to add?
One thing on the breast case is, and I'm not sure, he may have said it and I may have missed it, is genetic testing. You always want to do genetic testing for any patient with breast cancer. That's a common pitfall that people forget, and then they'll keep saying, "Do you want to do anything else? Do you want to do anything else?" And usually it's genetic testing. Same thing for pancreatic cancer, genetic testing for all. And then the other thing is just be careful with systemic chemo regimens. They can ask more and more questions about that. So I think on the safer side, it would just be to say, I would refer for systemic therapy. And then if they want to ask you what regimen, because you can get into the weeds with that, they may start asking you, side effects of certain chemo regimens if you just go ahead and offer that up. The other thing was on the intussusception case. There was no air on the right side of the abdomen. So I would just be really cautious doing approaching that laparoscopically. Those cases of bowel obstructions with intussusception are high risk for bowel injury. So that's a common complication that they can give you. So just be aware that could be, a complication if you do proceed to start, minimally invasively. Otherwise, I thought he did a great job.
And then I think just from style points, I thought again he made good eye contact. He was confident. One of the hardest things is the pivot, right? And I think when you start getting these questions and then the examiner starts pivoting and changing the scenarios a little bit, you really have to sort of think back to what you were talking about, what you were doing, and how you would do it differently. But he was very well poised when that happened. And there was multiple pivot points in each of those cases, which I thought was a nice twist for him. But he handled it really well.
Yeah, definitely agree. Yeah, I thought it was a good example of just how you need to, I think, keep your composure, even as I think Dr. News would kind of repeat questions and then very quickly change the scenario. And, I think Ryan would ask for things and they just wouldn't work or they just wouldn't be remarkable. So I think definitely a great example.
A good example of the fact that your examiners want you to do well. They will redirect you when you stray. It's important to listen to their cues. If I could add one more thing about the breast case, something that I've picked up in surgeon fellowship is you should really never say the words, uh, her only option is when it comes to breast cancer. I mean, there are just so many different ways to manage everything and patient preference. And so try to avoid those in breast cases, especially on general surgery boards. Um, we can move forward to Dr. Rossi's case now. Let's share that real quick.
Right. Hello, everyone. My name is Alex Rossi. I am a junior faculty at Yale in the colorectal surgery division.
I'm Russell Pepe. I'm a PGY4 general surgery resident at Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey.
Awesome. And we are going to do 2 scenarios here. I'm going to set a timer for 7 minutes, just like the actual boards, and we will get started. All right. First scenario, you are covering the on-call service. You're called to the emergency room to evaluate a 45-year-old female, 5 years status post of Roux-en-Y gastric bypass, who's presenting with epigastric and right upper quadrant abdominal pain. She has associated nausea, but she has not been febrile.
Okay, I would go see the patient, get a thorough history, including any additional operations that she's had, whether she's had any associated symptoms that seem kind of like obstructive or bloating type symptoms, nausea and vomiting.
So she has had nausea, vomiting, but no obstructive symptoms. She's having bowel function. She's had no other surgeries. She did not have a cholecystectomy at the time of her gastric bypass.
Okay. I would get a full set of labs focusing on whether she has a leukocytosis. Given her right upper quadrant symptoms, I would make sure that I include LFTs and a lipase in those labs. And I'll likely start with a right upper quadrant ultrasound as well.
So on laboratory analysis, she has a white count of 9. LFTs show a mild transaminitis and a hyperbilirubinemia to 4 of T-bili. Right upper quadrant ultrasound shows cholelithiasis without signs of cholecystitis and a CBD of 12 millimeters.
Okay. So my concern here is that this patient has choledocholithiasis. I would discuss with her the need to clear the ducts, but given her history of Roux-en-Y, I would need to go through kind of the complicating factors and what we would need to consider. Her options would be either a laparoscopic cholecystectomy with a planned intraoperative cholangiogram during that operation, or we could start with a laparoscopic transgastric ERCP, but I would need an endoscopist, GI, available for that.
Okay. So you talk to the patient, and she says that she would prefer you to do the gastric thing. So walk me through that procedure, please.
So for the lap transgastric, this would be the plan is to try to get a port that you can get a duodenoscope through into the left upper quadrant. So you would start out laparoscopically with a camera port periumbilically. Once you identify where the remnant stomach is, you would have 2 other assist ports, 5 millimeter assist ports. There are 3 5 millimeter assist ports, 1 in the right upper quadrant, 2 kind of on the left side, and intend to place a 12 millimeter port kind of right about where you anticipate that you'll be able to get the ERCP into the remnant stomach. At that time, I would place transfascial stay sutures into the anterior surface of the stomach on the greater curvature, and place a 12 millimeter port first through the abdominal wall, or I would use one of the other assist ports to make a gastrotomy, and then get a 12 millimeter port through the abdominal wall and then into the stomach, and then proceed with an ERCP through the remnant stomach.
Okay. So you do all that, and the GI goes to stick the scope into your port and doesn't fit.
At this point, I mean, I would probably, well, at this point, I would need to, is this an advanced endoscopist?
Yes.
So if it's an advanced endoscopist, I would ask them to perform a ultrasound guided the edge procedure going through the stomach or through the esophagus into the remnant stomach that way, and for like to gain access, kind of the usual way, but connecting through a stent.
Okay, let's go back a step. And so you put in your port, you put in a 15 millimeter port, and the endoscopist is able to complete his ERCP successfully. How are you closing the gastrotomy?
I would close the gastrotomy, over sewing it, full thickness bites, make sure that I have a piece of omentum that I can, um, fix with those sutures, like a gram patch or modified gram patch.
Okay. And going back 2 steps, the patient, when you gave her the options, actually said, okay, do the gallbladder thing. Just give me the broad steps of that. Your plan.
Would set up for the cholecystectomy in the usual fashion, periumbilical, subxiphoid to right upper quadrant ports. Proceed with, the initial steps of a laparoscopic cholecystectomy, obtaining the critical view of safety, clearing out the hepatocystic triangle. At the point where I've achieved a critical view of safety, would ligate the cystic artery and place a clip at the infundibulum of the cystic duct, and make a ductotomy in the cystic duct right below that clip. And then I would then pass the
All right.
the
We're out of
catheter
time
into
on that one. Thank you. All right. Let me reset the timer here. Okay. Second scenario. You're on the on-call general surgery attending, and you're called to the emergency department to evaluate a 34-year-old female with a known history of severe ulcerative pancreatitis, who presents with profuse bloody diarrhea for the past 12 hours. Her last colonoscopy was 6 months ago and showed extensive inflammation throughout her colon. She's currently on mesalamine and infliximab for medical treatment. Her vitals in the ED show she's tachycardic to 124, she's hypotensive with systolic in the 80s, and on physical examination, she appears pale, ill, and diaphoretic. Her belly is mildly distended and soft, and there is gross bloody stool on DRE.
So her diagnosis, I'm sorry, was 6 months ago?
No, her last colonoscopy was 6 months ago.
Okay.
She's long-standing.
Long-standing ulcerative colitis, on maintenance therapy, but with an acute flare in this presentation. So I would see her in the emergency department, get a set of labs, and make sure that if she needs blood resuscitation as part of her resuscitation, that would be included. But I would certainly make sure that she was resuscitated, if not with crystalloid, in keeping with the Surviving Sepsis campaign. After she is adequately resuscitated, while this is going on, I would get quickly an upright plain film initially. And if she was stabilized, I would want contrast enhanced imaging to see the extent of her inflammation.
So initial labs come back. Her hemoglobin is 6.8, down from 12 2 weeks ago. Her lactate's 2.5. Her albumin is 2.8. You get an upright X-ray, and it is unremarkable. What are your next steps?
I would, after she's resuscitated, I would proceed with a CT with IV contrast, as well as I'd be talking to my gastroenterology colleagues to see if we could do at the minimum, a sigmoidoscopy to evaluate the rectum and colon.
GI says that they are unwilling to come into the hospital, but the patient is being resuscitated and her blood pressure is not improving and she remains tachycardic and hypotensive.
Okay.
No.
At this point, I'm sorry, I didn't catch that last part.
She has not made it to the CT scanner yet.
Okay. If she is remaining unstable, CT scan would not be indicated at this point. I would proceed with consenting. I'm going to first make sure that I'm ruling out infectious etiology as well. Make sure that I'm going to include infectious etiology as part of that lab workup, but I'm going to proceed to the operating room planning for subtotal colectomy here.
Okay. And the patient asks, so you're going to cut out my colon. What are you going to do? Are you going to hook me back up?
Because of how unstable she is, the plan would be to not put her back in continuity. The plan would be for an end ileostomy and planning for later completion, which I would need to know. Part of that history involves discussion of her history of continence, or incontinence, rather, fecal incontinence, to make sure that should be for like down.
The patient says, "Okay, go."
So this would be a midline laparotomy. Total abdominal colectomy would medial to lateral dissection starting at the sigmoid, eventually mobilizing the full sigmoid, descending colon, splenic flexure, getting into the lesser sac and mobilizing the transverse colon, hepatic flexure, and then all the way down the ascending colon and terminal ileum, at which time I would then take all of the colonic vessels after the full mobilization. The extraction, after extraction of the colon, I would bring up the ileostomy in the preoperatively marked ileostomy site, which would have avoided any folds or scars in the abdomen, mature the ostomy, and for the rectal stump, just because I'm leaving an inflamed rectal stump, I would probably oversew the staple line to try to avoid a blowout before closing the fascia.
Okay. And is there anything else you'd like to do to manage your rectal stump? Or rather, are there any other options that you could consider?
Yeah. So you could bring up the rectal stump into the midline wound so that if there were a blowout, this would be matured as a mucus fistula. There are descriptions of leaving a Malacot in the rectum transanally to decompress it in the early postoperative period, but unclear what the benefit there is.
Very good. So you do all that. Patient tolerates procedure well. She recovers well in postoperative period and is discharged. And she gets her UC under control and the rectal stump. And 6 months later is asking, what's next? She has full continence.
She has full continence. So at this point, I would be planning for, after nutritional optimization, I would be planning for eventual reconstitution through creation of a J pouch.
That's all the time we have. Thank you very much.
Thank you, sir.
Dr. Rossi, thanks so much for joining us and thank you for recording that. Eager to hear your thoughts. We did a lot of word prep together, so I think I know what you're going to say.
Yeah, so I'm sure you guys saw this is actually I'm glad these cases went the way they did because I think it's important that some missteps are made and kind of important missteps broadly were made and not that Russell did a bad job, just he made some common errors or fell down some pitfalls that are best avoided. So first case, I thought he was doing pretty well up until the comment I made that the scope doesn't fit down a 12 millimeter port, which then kind of derailed him. And the important thing is to just take a moment when an examiner asks you a clarification question or changes up the scenario a little bit, just stop, take a second to think about what is being asked and what's being said, and don't panic. Russell unfortunately sort of panicked and then jumped into talking about an edge procedure, and like that really wasn't where he should have went at all. He should have just thought about what was the problem. The problem was the scope wasn't fitting in the port, so either he needed a smaller scope or a bigger port. But also another pitfall of being overly specific. If he didn't say it was a 12 millimeter port and he just said it was a large port, I wouldn't have said anything after that, and he would have gone on and with the scenario. So sometimes you can be your own worst enemy. A couple other points about that scenario. Earlier on, when he was talking about either doing cholecystectomy with a cholangiogram and some kind of intervention, he never actually said an intervention. He said with a planned intraoperative cholangiogram, which is an imaging study. So there is another step to that that he didn't actually verbalize. I know he intended to, but that doesn't count for anything. And then also the gastric closure. This is a surgical wound that you're creating. There's no reason that you need to do a gram patch or a modified gram patch or anything like that. Either close this in two layers or just staple it off. It's on the greater curve of the stomach for a reason. But otherwise, I thought he did pretty well with that scenario. In the second scenario, he kind of vacillated between doing well and also being way off base. Very simply, the patient was bleeding to death. He kept talking about sepsis, which was fine, but just focus on what's being told to you. You've got a bleeding patient with pancolitis. You know they have pancolitis because the scope 6 months ago showed you that. He called it maintenance therapy. She was never on maintenance therapy because she wasn't controlled. So essentially, she's just uncontrolled UC and she's bleeding to death and is in hemorrhagic shock. So very simply, you don't need imaging. You don't need really very much. You need to resuscitate and get to the operating room, do your subtotal colectomy. Just don't overcomplicate it is really the take home on that. And in terms of some other finer points, a medial to lateral dissection is not commonly done in an open case. It's more of an MIS approach. Again, overcomplicating it. And then the last bit at the end, he actually preempted what was going to be the complication, which was a stump blowout, by saying, I don't even remember what he said he was going to do, but he said something, so that made me ask, okay, well, what else can you do about that? Just to suss out some other options. And another thing I wouldn't recommend doing is don't say there's been descriptions of or literature suggests or anything like that. This is an exam about what you would do in a situation. So you don't need to clarify like, oh, I read this in a paper once. You just, if it's something that's known or reasonable or whatever the reason is that you want to do it, just say you want to do it. And that's fine.
Yeah, I think it's important to remember that this is a test that's intended to decipher whether or not you're a safe general surgeon. And if you find yourself talking about the cutting edge of technology and edge procedures and things like that, you may be headed down the wrong path. Dr. Reddy and Dr. Freeman, eager to hear your thoughts on this case.
Yeah, so one thing is it's always important to have your name properly listed out on the Zoom call. So I noticed that his name was sort of spelled without any spacing. That's just a simple thing. But I thought for the gallbladder scenario, just like they commented on, um, you have to be careful. Some scenarios are going to be very operative heavy, just like these both these cases were. So you got to be prepared for this. And Dr. Rossi's right. As soon as he got the composure aspect of things sort of went awry, he went down just a dark path, and it was really hard to pull out of. And I think you got to be careful about that. Second case, also, just do the safe operation, right? This patient was unstable, bleeding. The safest thing is just what he ended up doing, but be careful with how much information you offer because then the examiner will it's like blood on the water. It's circling out there. They can then go down another path and it makes it a little bit more difficult. So be somewhat reserved to your questions or your answers and your responses, and I think it'll usually fall in your favor. Otherwise, the tough cases, but good job.
Yeah, I don't have too much more to add. I think the description of the procedures, there was maybe a little too much time talking about where the ports were being placed and that kind of thing. That's something that I noticed, especially on the first case. So I think if you're going to do something in minimally invasive fashion, just say, I gain entrance into the abdomen and triangulate my ports, and then start discussing the operation. That's one thing I noticed. The other thing, this is a fine detail, but I'd probably get imaging to confirm that there's choledochal lithiasis. You had a dilated common bile duct, but not definitive evidence of a stone. So I'd probably get an MRCP in that case prior to proceeding to the operating room. But it wouldn't be wrong to do a lap chole and a intraoperative cholangiogram without an MRCP, but just for more operative planning, and then agree with the previously stated comments on the second case.
Excellent. Let's move on to your video, Dr. Friedman, and that'll take us to the finish line here.
Okay, Dr. Hill, I am going to set my timer for 7 minutes. This will just be a case like we're in a lounge talking about a patient as colleagues. Standard ABS rules apply. I'll give you some patient information and we'll just kind of go through the case. As soon as the 7 minutes is up, we'll move on to the next case.
Okay.
Okay. All right. First case, you have a 70-year-old gentleman with hypertension, hyperlipidemia, and he's a current smoker. He smokes a half pack per day for 40 years, who presents to you in consultation in the ED for temporary vision loss in the right eye, consistent with amaurosis fugax. This happened at home. The vision loss lasted about 1 minute, and then his vision spontaneously restored. And returned to baseline thereafter. This, of course, prompted a visit to the ED. He's with his wife. A CT head with and without IV contrast has already been done, which showed no evidence of hemorrhagic stroke and no parenchymal ischemic changes. The ED physician performed a visual acuity exam, which was normal. So you present to his room. He's alert and no acute distress. You question him and he denies experiencing any motor weakness, sensory deficits, or additional symptoms. His wife reports he has never shown signs of facial droop or slurred speech. The patient is adopted. Like I said, he's a smoker. He is on amlodipine for hypertension and atorvastatin. And his vital signs, he's afebrile, blood pressure is 140/70, heart rate of 75, respiratory rate of 10, and he's satting 100% on room air. How would you like to proceed?
So the only other things I would want to ask him is if he'd ever had this happen before.
He denies ever having anything like this happen before.
Okay, and then I would I would perform a focused physical and listen to his carotids bilaterally.
Okay, his physical exam is unremarkable. What are you listening for when you listen to his carotids?
I'm listening for a bruit.
Okay, you don't hear a bruit on either side.
Okay. So I would discuss with the patient that I'm concerned about some sort of carotid stenosis because of his past medical history. his smoking history, and then also this episode of amaurosis fugax. I would obtain some lab work, a CBC, a BMP, and then I'd want to get a duplex of the neck bilaterally.
Okay, labs are unremarkable. You order a bilateral carotid artery duplex ultrasound, which shows on the right side he has elevated flow velocities consistent with 60% stenosis. And on the left, he also has elevated flow velocities consistent with 80% stenosis. How would you like to proceed?
Okay. And I'm so sorry, can you repeat which side he had the vision loss on?
On the right.
Okay. So in this particular situation, I would discuss with him that while he is a candidate for, carotid endarterectomy on both sides, I want to address this right side first because he's had symptomatic signs of a stenosis on this right side. So I would discuss with him proceeding with the carotid endarterectomy on the right.
Okay. When are you planning on doing that?
Within the next 2 weeks.
Okay. Is there anything you want to get prior to surgery?
Yeah, I would go ahead and get a CTA of the neck as well to confirm these ultrasound findings.
Okay, you order a CTA of the neck and findings are consistent with the carotid duplex bilaterally, 60% stenosis on the right, 80% on the left. Anything else?
I would discuss with him the importance of smoking cessation.
Okay.
And then also make sure he's on an aspirin and a statin. It sounds like he's on a statin. I'd make sure that's high dose.
Okay. All right. So you said you were going to proceed with the right-sided carotid endarterectomy. Could you, in a few steps, explain your operation?
Yeah. So I would bring the patient to the operating room. I would perform an incision along the anterior border of the sternocleidomastoid, dissect down through the platysma, through the facial vein if necessary, enter my carotid sheath, making sure to protect the vagus nerve. I would then clamp the internal common and then the external carotid after heparinizing the patient. I would then check a stump pressure and shunt selectively as needed to maintain cerebral perfusion. I would then perform an endarterectomy extending along the internal down onto the common carotid, perform my endarterectomy, removing all the plaque, removing all the debris, tack down any loose edges as needed, and then I'd get backflow from my internal and external, and then forward flow from my carotid, each individually, perform a patch angioplasty, heparinize again, and then Doppler my artery and close the neck in layers.
Okay. You said stump pressure. What is your stump pressure required for shunting if you do this selectively in your practice?
I would look for a internal carotid shunt, or excuse me, internal carotid pressure of greater than 50 to 60.
To not shunt?
Correct, yes.
Oh, okay. All right, so you finish your operation, everything goes well. The patient awakes in the OR. You check for any deficits, there are none. He goes to PACU. You get a call about 7 minutes later from PACU, and the patient's complaining of a terrible headache, and his blood pressure is 180 over 100. How would you like to proceed?
So I'd go and assess the patient. I'd want to keep his blood pressures between systolic less than 140 following the case, and see if that helps alleviate his headache.
Okay. The nurse is concerned because his pressure, as you're talking to him, is now 200 over 120. What do you think this is, and how do you want to work it up and manage it?
So, worst case scenario, this is like cerebral hyperperfusion syndrome. So I'd want to treat his blood pressure pretty aggressively and start a cardine drip, getting his systolics in the 140 range.
Okay. Any workup that you'd like to do for this patient?
I would get his blood pressure under control first.
Okay, all right. We're out of time for that case. We will move to the next case. This is going to be our last case here. Let me reset my timer. Okay, this case, you have a 60-year-old gentleman who is previously healthy who presents to your office in consultation for a pancreatic tail lesion. This was discovered on CTA of the abdomen, which was done last week in the ED after he was involved in an MVC. Luckily, he had no acute injuries and he was discharged from the hospital without patient follow-up with you. The pancreatic tail lesion measures 2.5 centimeters. It's well demarcated and shows hyperenhancement on our arterial phase. He's previously healthy, has never had surgery. He has a mother with hypertension and a father with prostate cancer, no alcohol, tobacco, or drug use, and he is not currently taking any medications. How would you like to proceed?
Okay. So it sounds like we have a pancreatic lesion and patient sounds fairly asymptomatic. I would just want to double check with the patient that he hasn't been having any new symptoms, any abdominal pain, nausea, vomiting, and go from there.
Okay. He says he's been feeling well. He's been in his usual state of health. He just feels a little bruised from the MVC, but no specific complaints.
Okay. I would discuss with the patient that this could be a number of things, but I want to get a dotatate PET scan initially to look for a neuroendocrine tumor.
Okay, he's sitting in your office. Is there anything you'd like to do before you start ordering imaging?
I'd get some generalized lab work first, CBC, CMP.
Okay.
First.
He says, Doc, do you want to do a physical exam? So you do a physical exam on him, and his abdomen is soft, non-distended, no palpable masses, otherwise completely unremarkable. And his vital signs are all within normal limits. And you said you wanted to order some labs. What labs did you want?
CBC, CMP.
Okay. No abnormal findings on labs.
Okay.
So how would you like to proceed from here?
I would like to get a dotatate PET scan.
A dotatate PET CT, okay. So you order that. It shows, again, about this 2.5 centimeter lesion in the tail of the pancreas, which is dotatate avid. You do not see any additional lesions within the remainder of the scan.
Okay. So the fact that it's dotatate avid makes me think that this is a pancreatic neuroendocrine tumor. Given its size, despite the fact that it's asymptomatic, I do want to, I'm going to go ahead and get an endoscopic ultrasound and FNA.
Okay. So you consult Advanced GI. They perform the EUS with FNA. Pathology from that shows sheets of small blue round cells, which are identified as enterochromaffin cells. The tissue does stain positive for chromogranin A, synaptophysin, and neuron-specific enolase. The findings in the pathology report are consistent with a well-differentiated grade 1 neuroendocrine tumor, Ki-67 of 2% and a mitotic rate of 1 per 2 millimeters squared.
Okay.
How would you like to move forward?
So this is a low-grade pancreatic neuroendocrine tumor, but it is greater than 2 centimeters, so I do want to proceed with a resection. I would proceed with a distal pancreatectomy.
Okay. Would you include a splenectomy in your operation?
Given that this is low grade, no, I would not.
Okay. Let's change the scenario a bit. Let's say that the same patient, and we're just going to kind of rapid fire through these. Let's say it's the same patient who presents with a non-functional pancreatic neuroendocrine tumor less than 1 centimeter in the tail of the pancreas. How would you advise the patient to proceed?
I would discuss surveillance with this patient, especially if it was found incidentally. I mean, they have no symptoms, very low chance that this will become anything dangerous or larger. So I would perform surveillance with a repeat CT scan in 6 to 12 months.
Okay. What about another different scenario? Same patient is diagnosed with a well-differentiated, this time a functional pancreatic neuroendocrine tumor with symptomatic hypoglycemia, which is resolved with glucose administration. This measures 1 centimeter in the head of the pancreas. It's 3 millimeters away from the pancreatic duct. So findings are consistent with a 1 centimeter insulinoma in the head of the pancreas.
Okay. So given that it's 3 millimeters away from the duct, you said, I can perform an enucleation of this mass.
Okay. Next case, again, same patient is diagnosed with a well-differentiated, non-functional pancreatic neuroendocrine tumor, which measures 2 centimeters in the head of the pancreas, associated with scattered innumerable bilobar liver lesions consistent with metastatic disease. How would you like to treat that patient?
Did you say we had a biopsy of this already?
Yeah, there was a biopsy done of one of the liver lesions consistent with metastatic disease.
Okay, and I'm so sorry I missed this. What was the grade of the neuroendocrine tumor?
It's a well-differentiated, non-functional pancreatic neuroendocrine tumor measuring 2 centimeters in the head of the pancreas, metastasized to the liver, innumerable bilobar lesions.
Okay, so if I do not feel like I can resect at least, 79% of this disease burden, then I'm not really doing the patient any favors with resecting everything. I would definitely discuss this with a multidisciplinary tumor board, get genetic testing,
Okay.
and long-acting octreotide.
Okay. I think we're done there. Thank you so much for your time.
Thank you.
I think there's another great 2 scenarios. Thanks to Dr. Freeman and for that scenario, and also Carlin. I think I saw she's on the Zoom as well, so thanks to her for volunteering and tuning in. So Dr. Freeman, we'll start with you. Similarly, what are your thoughts on the scenarios and kind of strengths of Carlin's approach, and then any kind of tricks or anything else you felt that she could have done?
Yeah, I thought overall she did a great job. Carlin is a 4th-year surgery resident at the University of Kansas, so appreciate her time. She had just finished a case when we did these. I think she did a great job on the carotid. The one thing I was trying to get her to say was to do an EKG. You always need to rule out AFib in a patient that's had stroke-like symptoms. So EKG, if they have a significant cardiac history, you want to do an echo. But that's really about it on the carotid. I thought her flow was good. I thought her description of the procedure was excellent. I think she passed that scenario very easily. On the PNET, the first scenario that I gave her, this was a 2.5 centimeter lesion. So I would do an oncologic resection for any neuroendocrine tumor greater than 2 centimeters. I think that's safe for any neuroendocrine tumor on the general surgery board exam. I would order tumor markers. You don't know for sure that it's a neuroendocrine tumor. I mean, the CTA results were highly suspicious of such, but I would still, get your CEA, CA19-9, CA125. And then I think it's safe with the dotatate PET CT for staging, but maybe just say, I would stage the patient to include a dotatate PET CT. But otherwise, yeah, I would do a splenectomy for an oncologic resection greater than 2 centimeter tumor. Enucleation is appropriate for an insulinoma less than 1 centimeter if it's greater than 2 millimeters away from the duct. And then management of metastatic neuroendocrine tumors is fair game. I think systemic therapy. There's, other regimens, radionuclide, et cetera. I don't think they're going to get into the weeds on that on the exam, but taking care of, inoperable disease is a fair question for them to ask. Overall, I think she did an excellent job.
Yeah, definitely some great points, and kind of like some of our previous mirrors, a lot of good pivots there from something that's like clearly operable to something that you need to think a bit harder about. Dr. Reddy, Dr. Rossi, do you guys have any thoughts and things that you'd like to add?
Yeah, I think again, I echo that sentiment for Operation One. Really described the operation well. I haven't not done any of those operations in a long time. It was very clear and it was nice. For the second scenario, I think there's a couple things. So the buzzwords can lead you down again a bad path, right? The arterial hyperenhancement was immediately like triggering in your head as a neuroendocrine tumor. But you got to remember your methods, right? Remember that thing we talked about with the flow, like you got to go through every step. She jumped right to the dotatate scan, which I think it's not wrong, but a lot of the times they won't even cover a dotatate scan without a tissue diagnosis. So, going through the steps, getting the labs, just like Dr. Freeman said, are important. Getting the endoscopy. You also have to know about the grade. I think the grade's important for these types of tumors. But then she ended up sort of, again, getting everything correct as she moved forward. For that last scenario, the metastatic scenario, I think asking for the biopsy is important and asking for the grade is important because sometimes if it's a high grade tumor, you're getting an FDG PET. If it's a low grade, you're getting a dotatate. It's probably, again, a little bit in the weeds for general surgery scenarios, but nonetheless, I think it's something to at least be cognizant about. But otherwise, really good job.
Yeah, and one thing I wanted to point out that I actually really liked was when asked, a pivot, a complication, whatever. I liked that she just took a moment, didn't say anything, didn't just like blurt out some random, whatever. Just took a second to think about it and then said some composed thought, which I thought was actually good style points. And then just a little thing with the carotid. A lot easier if you just shunt everyone. If you say selective shunting, they're going to ask you what your stump pressure's got to be. If you just say you shunt everyone, they're never going to ask you.
All right, well, thanks everyone. I think that's our last scenario thing. So before we leave, I just want to thank all our participants, our panelists, Dr. Reddy, Dr. News, Dr. Rossi, Dr. Freeman, and of course, our four mock examinees, David from Fox Chase, Ryan from UT Southwestern, Russell from Robert Johnson, and Carlin from Kansas City. We appreciate everyone volunteering for this and helping everyone in their preparation for the oral boards. Prav, I'll turn it to you for any last thoughts, closing comments.
Lovely working with you and everyone, as always. Thank you for joining us, and thank you to the incomparable Bev Hendry for all the logistics and setup and recording. As always, perfect execution. Have a great night, everyone, and thanks for tuning in.